So I'd like to open, we have about a half hour for questions, or maybe a little less. So if anyone has questions for Dr. Statland or Dr. Tawil or Denis Tidwell, ask away.
The biggest concern that I have with donating tissue is making sure that it is open access to every single researcher who wants it. So by going through NDRI versus going specifically through a clinician, can I ensure that this is going to be open access and not bound by any legal means to only one specific researcher?
So going through NDRI, we work specifically with the researchers. So we don't have the tissues available to anyone. We vet the researchers who are interested in the tissues, but the ones who are registered with us are the only ones that receive those tissues. I believe that answers your question.
Yeah. So any researcher with a valid project can apply and be on the list to receive it. So
Yeah.
a single recovery event might actually supply tissue to multiple labs.
To multiple researchers,
Yeah.
correct.
Mm-hmm.
You know, during this meeting, several points have become evident to me and may find a vehicle to improve communications on FSH. First, we've got a number of pharmaceutical companies and scientists present here that are looking for lots of input from FSH patients. Second, there's lots of FSH people here, although we represent a tiny fraction of the people affected by this disease. And all of us are looking for solutions, for treatments, for cures. We want that, and several questions have arisen as a result of it. Third, Dan pointed out that we need money. We need an increased level of donation to fund all of this activity. So I'm going to suggest something, June, that may help in this area. Many of you are aware of or participate in local sessions, FSH sessions across the country. And I go to one in New Jersey periodically when those sessions are available. And they're useful and they're beneficial. But the ones that have the biggest impact are those that have a scientist or someone from a pharmaceutical come in and talk about solutions, where they are, the kind of thing we've just seen here over the past couple of hours. But those people, people like those who are here today speaking, we don't get those into these local meetings very often. And I don't think that it's because they're unwilling. I think it's because they're not asked for. It's not requested enough. I believe that if we had some of these people come in and speak to local FSH groups, we would get a much bigger audience. And by the way, not just FSH, but recently the Muscular Dystrophy Association in our area had an FSH speaker at one of their sessions. So even going into that kind of an environment might be useful. Now, for me, if I saw something really encouraging, and that's the reason I come to these meetings, seeing something really encouraging, it would stimulate more reason for me to contribute and contribute more aggressively. So what I would suggest is that the FSH Society put together a program that says, okay, we've got pharmaceuticals, we've got scientists that are willing to speak within some geography. And they identify what that geography is. We take that information and we get that at minimum to the FSH groups that gather together across the country and allow them to invite those speakers in to provide the kind of insight and encouragement that we see here, and go in with the intention not only of informing, which will be encouraging to the patients, but also to find ways to increase contributions to the FSH Society that obviously will benefit everyone here. So I just suggest that we take a look at putting that kind of program together in June. If you need help, I know you have an extensive staff that does all this kind of stuff, but I'm more than happy to get involved in that as well if that is something that you're willing to pull together.
That's a great suggestion, Bill. Thank you. Other questions? Yeah, okay.
Hi, my name is Andres. I'm from Venezuela. I'm here for my brother. He was diagnosed when he was 8 years old. Now he's 18. And he's losing weight. And I want to know, and my father as well, if there is any kind of food or nutrients that people here as patients or the staff know to people to eat, because we notice that he's still losing weight, and we at least want to trying to stop that and make it like easy for him to walk. He's still walking, but he's constantly falling. And I don't know if someone here knows about that. And the question is open to everyone or someone who knows about that. Thank you.
So I'll take a try at that. I mean, this is a difficult problem, but it's also, I mean, one has to be careful, you know, to kind of balance, you know, we don't want somebody to keep losing weight, but at the same time, if your brother is very weak, you don't want him to gain a lot of weight also, because that's going to limit his function. So it's kind of a balance. And, you know, I think going to a nutritionist and talking about that, and the nutritionist can look at what he's eating, and they can make suggestions about the amount of calories that he needs. Again, but the nutritionist has to be aware that your brother has a muscular dystrophy and that his muscle mass is not going to be like somebody of the same size who doesn't have FSH. And so, and we don't want him to, we don't want him to continue losing weight, but you don't want him to gain too much weight at the same time.
I have something to add to that. Do you guys know anything about oxandrolone?
Yes, it's interesting that you asked that. Actually, we were involved, I was involved with a study with Ohio State University with Dr. John Kissel using albuterol back in late 1999, 2000. And there was a signal of increase in muscle mass that was dose dependent, so it was very reliable, but it was not enough to cause improvement in strength. And so our next step was we actually applied to the FDA and got an approval to try a combination of albuterol and oxandrolone. Oxandrolone is a steroid derivative, testosterone derivative. And we thought that cycling those two drugs may actually result in improvement in muscle mass and strength. Unfortunately, the drug companies that volunteered to give us the drug for the study then pulled out. They were not interested in doing it. So, I mean, the answer to your question is we don't have any evidence that it works in FSH because we were never able to do the study at the time.
Yeah, well, I heard in AIDS that they use oxandrolone for weight gain, so I don't know if that would help in any way for that guy's case.
Yeah, I mean, there are a number of drugs that are used in AIDS, but again, I mean, I think this is, in AIDS, it's really what we call a catabolic state where you're losing muscle mass because of a systemic disease, which is a little bit different than the situation in a muscular dystrophy.
I have a question way over here on the side. I think it's great that you guys have developed a network of trialists, but unfortunately not all people with the disease live in Baltimore or Columbus or Kansas City or Los Angeles. And I'm wondering if you've thought about ways to reach patients who can't get to you. Either training people to do their own data collection in a validated and reliable way, or developing a network of clinicians embedded throughout the United States or many communities who you could work with, so you could gather data from a lot more people without creating the burden of traveling to your sites. Seems to me that would be a great way to rapidly collect much more information, and especially in the era of telemedicine, there might be ways where you could actually have the visits directly to them, so you could observe those patients and gather some of the information yourself.
Yeah, and that's a really important issue, but there are some limitations. I mean, some of it is, I mean, we are willing to expand as much as possible, but again, you cannot have a network. It's expensive to train and maintain the readiness at those sites, especially if there are no ongoing trials. If there are trials that are going on, then I think it becomes much easier. But at the same time, I think it is important, and when I talk to drug companies who are doing trials, I really kind of emphasize the importance of, of including the cost of travel to the sites, because, and we do that in our non-intervention studies when we're doing natural history studies. I always put a budget in to any application to allow patients to come to the site, because these are, most of patients with FSH have, day jobs and they're busy, and, if they have to take off, it's a hassle. And I think drug companies should do that for especially these rare diseases, because that's one way of also making, I mean, there's either that or having more sites. But there's always an issue of recruitment in any trial. You want to get the number of patients as quickly as possible so that you can get the study done. And so it really is kind of really efficient to include that in the budget for any study. As far as, again, some of it is limited by the type of intervention. If it's an oral drug, it's very easy to give it and send somebody away for 3 months and have them come back. It becomes much more difficult when you're talking about an intervention that requires somebody to be present at the site every week or every 3 weeks or 4 weeks. Telemedicine is something that everybody's interested in. It is difficult. I think that it is applicable to certain diseases, that conditions like Parkinson's disease, it's being developed very nicely, because the evaluation of these patients is much easier to do in a telemedicine setting, whereas trying to do the same in muscular dystrophy is a little more difficult, and you need more space, you need more, staff to be able to do that, and you need a lot of training. So it's not impossible, but I think this is something that we need to look at, but it's not a short-term solution, I don't think.
Yeah, well, I mean, I think one thing that you're pointing out, and a number of people have mentioned it, would be the idea that can we get this natural history data from people all over the country versus having to bring them in. And it's partly dependent on what the goal of the data you're collecting is. I mean, there's some data we need people to come in for because it's going to be the kinds of measurements that kind of require you to be present at a place where they'll know how to do the technique to prepare, so a company can use a tool for a clinical trial. But there are ways to get lots of very valuable information from people all around. I should point out there is the US registry, and just filling out those questionnaires if you join the FSHD registry is amazingly important. One of the first projects I did when I started working in FSHD was looking at about an average of 6 years of data from people who had participated surveys to that registry, and we learned a lot about the functional burden, about, you know, the incidence of having to start to use things like braces for the ankles or walkers, when did it happen, the relationship to genetics that we didn't know. And it was just there in the registry because people had every year filled out that form, and it was an amazing resource. In terms of collecting more quantitative data, I think Parkinson's disease is a nice model. They have an app, which I know I've shown June before, that they put together to do just this called Empower, where the patients download it and it collects some information about their gait, some questions about how they're doing. It has them do a few specific tasks, and then it can collect data on thousands of people. Now, it's not quite the same kind of very clean data we get when we can bring someone in and do it in a very controlled setting, but I think there'll be roles for both kinds of data as we move forward, and I'm certainly interested in this. But, you know, starting the network that you've heard about has been a huge amount of work, and so I think once that gets its legs under it and gets up and going, those kinds of ideas and that kind of thinking will really be useful, and you're welcome to give me that, to communicate and let me know if you have ideas towards this. Yeah.
Again, also just again to emphasize the registry, I mean, it has been going on for 16 years now. So we have 16 years of follow-up data on 800 patients. That's very valuable information, and Jeff tapped into that information. One of the shortcomings of it is that only half of the patients are genetically confirmed. So I review all of the records that come in, and so those that are not confirmed I'm not 100% sure that they have FSH if we don't have genetic confirmation. One of the things that we started doing now, we can actually double the value of this registry by getting patients tested, and we, with the help of the society and the Friends of FSH, we're going to do that at almost zero cost, $100 for every genetic test that costs $2,500. And we're going to offer that to the patients in the registry. And this is courtesy of my collaborator in Leiden, Dr. Vandermar. And again, I mean, it's really very valuable information. And the more suddenly, I mean, we can have double as much data on existing patients, even if nobody registers anymore into joins the registry. We can learn a lot more about FSH and the natural history of it just by looking at the registry.
Statlin, you took the words right out of my mouth, actually. I had set up a meeting with Empower, with Tapscott and Jones in June, talking about the Empower studies, how they have developed an iOS application for Alzheimer's. The key takeaway points was funding. Where could we get funding to develop an iOS or Android application that we can put out so that everyone has access to it, so they don't have to travel. And then the other takeaway point from those meetings were, what are some of the things that you would test for?
Yeah, so exactly. I mean, I think funding is always the barrier, but it's not like an insurmountable barrier. It takes will and effort, and this is definitely on my list. I think when I talk to companies about clinical trials, I'm always talking to them about the fact that the clinical trial of the future is one where we may be doing our measurements in the home setting, because the technology is getting there. Now, what will we measure is a little bit of a harder question. You know, the more changes you make to what's already out there, to take someone else's app and adapt it without making many changes is fairly cheap. To start to make a lot of changes becomes expensive. But certainly you can measure how people are walking, how much activity they do. You can get a sense for how active they are by looking at a region they cover in any given day. Yeah, and so there's a lot of, I think, things that could be important to measure.
I think we have time for one last question, just 1 minute.
I guess this question's more for Dr. Towell.
Yeah.
The question is, if the DUX4 gene in its normal state is non-expressive, why do we need it? Why do we have it?
So it's expressed in the testes and in some of the kind of cells in early development, and so it has a role. I don't think we've figured that out very clearly yet.
And that was the question, basically, have we looked into why it's there in a non-expressive form? Has there been studies around that? And the actual clinical study that's going on with Acceleron,
Yeah.
is there any relationship or similarity to an anabolic steroid with this
No.
drug? Okay.
No, I mean, the problem with the anabolic steroids is the whole host of side effects, because that's a hormone. When you target the myostatin pathway, you're really limiting the target of what you're looking at, just in kind of inhibiting a protein that actually suppresses muscle development, and so you're not affecting any other system in the body. There was one question.
Okay, one last question.
I'm just curious, when there's no history of FSH or MD in the family, how does one become a carrier?
So a carrier is somebody who's has a spontaneous mutation, a somatic, a mutation at a certain point in their early development. So not all of their cells carry the contraction of the repeat on chromosome 4. But if it ends up in their sperm or eggs, then they can pass that on as a full mutation to the next generation. And so, and that seems to be what happens when we see often somebody who's not affected, and then the offspring is affected, the child is affected.
Does it go down the family line?
Yes,
Does it get passed?
yes, yes, because the affected child is going to pass it on a 50-50 chance. There's a 50-50 chance of them passing that on.
All right, great. Well, let's thank our speakers for this incredibly informative afternoon.